Right, so I'd like to welcome you all. My name is Adelina Comas-Herrera. I'm the director of the Global Observatory of Long-Term Care that is hosting today's webinar. I'll just give a brief introduction to what's the observatory, and then we'll move on to hearing from the speakers. And today we're talking about dementia stigma, which is a very timely, very important topic, and an area where a lot of work still to be done. But we're very happy to be able to introduce today some fantastic work by colleagues internationally and in Kenya and Brazil. So that's all from me. And now going to hand over to my colleague from LSE, Sara Evans-Lacko, who is going to introduce this whole session and also the concepts of dementia and stigma. Thank you.
Okay, thank you, Adelina. And thanks to everybody for coming today and for organizing this session on what is such an important topic. And it's great to link up with this global observatory, and I think even the ethos, maybe some of what Adelina was talking about, really matches with what we'll be presenting today. This really kind of interdisciplinary work and working together with lots of different organizations, researchers, people with lived experience, and lots of other stakeholders who recognize the importance of addressing this issue around stigma. So I'm going to start presenting an overview of some of the work we did with the STRIDE project, which was about strengthening responses to dementia care. But we had a specific work package which focused on stigma, and which has also now spread into a web of lots of other work too, which we'll be sharing today together with the colleagues from Brazil, Chile. I think you put both of your affiliations down, Deborah, who led. But Deborah led work in Brazil about reducing stigma, and Christine led work in Kenya about reducing stigma as part of the STRIDE project. And then Wendy is also was an important part of the STRIDE project, but is part of this continuing force in terms of trying to think about how we can reduce stigma. And it's going to talk about some new work ADI is doing in anti-stigma survey. So I'm going to start with an overview just of our what we did in STRIDE, and then present the toolkit that we developed linked with STRIDE, and then I'll hand over to my colleagues. But just to start with a brief kind of background in terms of contextualizing stigma, because sometimes I think it can be seen as kind of a vague word. But to take it back to its historical roots, so we know the word stigma has a long history of being used. In ancient Greek, it was used to mean puncture or brand. Then Goffman, a sociologist, later really made this seminal book and talked about how stigma is an attribute that is deeply discrediting, reducing a person as an attribute, and reducing the bearer from a whole unusual person to a tainted and discounted one. And it's very eloquently written book if you're trying to think about the language used to describe stigma. But since then, there has also been some further developments. So I don't know why they're bouncing in, but and the most used definition of stigma now in the literature, in the scientific literature, is by Bruce Link and Joe Phelan. And I think it's important because it acknowledges that it's not just about having a stereotype or about someone with different conditions, but it's this really co-occurrence of different aspects that happen, and this process that happens when we are thinking about stigma, which first is around people really distinguishing and labeling human differences. So noting that there is a difference between certain groups. Then these labels, though, so it's not just about acknowledging that there are differences, these labels then need to be linked to undesirable characteristics. Those labeled persons are then viewed as an out group. And so there's this real separation between them and us. And then this often leads to some emotional reactions towards these labeled people. And this may include fear, repulsion, disgust. And that also then leads to the labeled persons feeling shame, embarrassment, humiliation. And that's, I think, one of the core features of stigma, this idea of shame. And of course, then this can have really important consequences for people experiencing status loss and discrimination. And I think also just important to note that stigma is really dependent on power. So it's usually someone in power who is then stigmatizing people who are not in power. Some of the medical sociology literature is complex in terms of how it's being conceptualized, which is important. But when we're trying to evaluate some of the anti-stigma programs, we really contextualize it in terms of knowledge, attitudes, and behavior. So thinking about knowledge or ignorance, attitudes or prejudice, and behavior or discrimination. So why should we focus on stigma in relation to dementia? And I think even there is sometimes where I get this comment, at least, that the world is changing a lot. People are really open about different conditions now. Is there really stigma? Is there really discrimination? Do we need to focus on this as an issue? And so together with ADI, I think we have some important data from the 2019 Attitudes to Dementia report. And so some of the qualitative work really emphasizing that the consequences of stigma, people noted, as really being described as bad or worse than the condition itself. And in our survey, we had 835 people living with dementia who responded. We asked them about experiences of discrimination in their everyday life. And so vast majority of people were really responding, saying that they do experience stigma and discrimination at least one area of their life. So quite a high number. But there's not a whole lot of work, especially focused on these experiences of discrimination from that perspective of people living with dementia. We did a scoping review for STRIDE and really focusing on what is the literature out there in relation to dementia stigma in low and middle income countries. We did not find very much. And I think that's also true in high income countries. So a lot of the literature focuses on clinical or care experiences. There's less literature about how these experiences impact people's social worlds, how that experience of dementia and potentially stigma and discrimination can impact those experiences. So these were some of the initial articles that we found in our scoping review, but they were quite limited. And so we have since added to the literature from the STRIDE project. So we felt it was important then to start really in a formative way, trying to understand people's experiences of stigma and discrimination, how it was being conceptualized, experienced, and considered by different stakeholder groups. So by people living with dementia, by caregivers, by general public, and also by healthcare practitioners. And so we now have some of this qualitative work published from Brazil, from Kenya, studies from India, and South Africa. And there are some coming out from Indonesia now also, and some additional papers which will be out very soon. And so, yeah, this was really exciting, really starting to build an evidence base around at least how stigma is experienced among people with dementia in different diverse contexts. And then this led to, so we had, this scientific evidence base building, but we wanted to also integrate it with really practical tools and advice to think about what can people do to change this context. And so we developed this anti-stigma toolkit called Don't Forget I'm Human. And that was one of the kind of perceptions that was really specific to dementia in terms of this dehumanization that people were responding in the qualitative interviews that really came out as important, and I think as more specific to dementia than some other types of stigmatized conditions. And so we called it "Don't Forget I'm Human." And the toolkit, so it's really rooted in voices and experiences of people living with dementia and their care partners. But we also try to think about how to work with the general public, with other types of stakeholders, health and care professionals, to make some behavior change and to mobilize large groups to really start advocating for reducing stigma. And so we discuss strategies for empowering people living with dementia to lead initiatives, practical advice, some project research evidence about how to reduce stigma and discrimination. And Deborah and Christine will talk about this later. And we did this in collaboration with a lot of different individuals, people working on the STRIDE project from the 7 different STRIDE countries, but also people with lived experience from those countries, in addition to research experts and advocates. And the idea is really not, we talk about the context and conceptualization and experiences that people are facing, but we want to really go beyond awareness raising. So the call to action is really to think about how can we change things, and also really, protect rights of people with dementia and their families, increasing access to equality of opportunity. I'm going to show just a quick video, at least, that it shows also some of the images in the toolkit and some of the videos from that. So I'm going to play this for you now.
Stigma against people living with dementia and their carers causes substantial impacts on their quality of life and well-being. In fact, people living with dementia and their carers often describe stigma as more impactful than the condition itself. Here we provide a set of practical tools to reduce stigma and discrimination and empower people living with dementia. The toolkit is part of the STRIDE project, Strengthening Responses to Dementia in Low and Middle Income Countries. It's a collaborative effort involving people living with dementia, their care partners, advocates, and researchers and experts in the field of dementia and stigma. It describes real-life accounts of people living with dementia and their carers, and provides evidence-based approaches and case studies of how we can reduce stigma and discrimination.
People experience it, but you never thought that one day that this would be hitting you, staring you right in your face.
The language people use and their action affect how we see ourselves. Many of us with dementia find our social circle getting smaller. People talk about us as if we no longer exist.
And stigma is not only among friends and social community. They are treated as an object, not as an individual.
Social change of this magnitude requires concerted effort over long periods of time at many levels. Here we try to provide evidence-based approaches and ways that you can adapt these ideas to reduce stigma and discrimination in your own context or setting and to empower people living with dementia. Our call to action is to go beyond really just improving knowledge and awareness around dementia and to addressing the unfair treatment and policies against people living with dementia and to reducing the social exclusion. To do this, people living with dementia need to lead the vision of what a world without stigma looks like. And we need to empower and work together with people living with dementia to make sure that we can enact this meaningful social change.
Yeah, so I thought that's helpful because it gives you a sense of, we try to make it very interactive toolkit, and really, share videos of people with lived experiences from a lot of different diverse settings. And this just gives a few additional highlights from the toolkit of what we try to cover. So we have, there are different chapters you can go to, where you can read people's own experiences of stigma and discrimination from different countries. And then there's, people's experiences of overcoming stigma, but also then some practical tips and tools that could be adapted to different settings in terms of How can we work together with people with lived experience? The importance of social contact that we know is the most evidence-based way to reduce stigma and discrimination. And then some examples of social contact are included also in the toolkit, thinking about selecting a target audience, a mix of really, examples of evidence, examples of people's experiences, and then also practical tools that can be adapted to run your own anti-stigma programs. I'm going to share one more thing from the toolkit. So it's just another person sharing their experiences of discrimination. So this is the online toolkit, and we included quotes of that people submitted about their experiences, and we've also people have shared this in their own voice too, which I thought will be helpful to hear. I'll just give a brief example here. Just to say, coming soon in terms of more evaluation tools. So we're still working on the research side. An important aspect of anti-stigma programs is to know if they're working and how they're working and who they're working for. So we're developing and adapting several different evaluation tools for this purpose. We have already actually the discus scale, which has been translated to maybe 25 different languages and tested in several different countries and validated. So, and that measures experiences of discrimination among people living with dementia. Soon to come, we'll have a stigma-related knowledge scale, and we're also developing other measures, stigma-related measures for the general public and healthcare practitioners and caregivers, ones that are more specific to these target groups. We've also developed items around concealment, social distance, intended behavior, anticipated discrimination. And a lot of these will be included in the World Alzheimer's report and the attitudes survey for 2024, which Wendy is going to talk about later. So just to share one last quote, there was Marinda, whose voice I was trying to play just now, and I will put in the link. She's the first audio clip, who is a person from South Africa living with dementia, who spoke, I think, really eloquently just about her experience of the challenges of stigma, feeling that for someone to accept that they have dementia is a difficult process. There is stigma. What I want is for people not to treat you differently. Don't speak about me as if I am not in the room. People will talk past you, but your close family and friends will understand. And I think she shares her story in the toolkit also, both about her challenging experiences, also some strategies she uses to overcome and cope with stigma. And right, a last call to action, just to invite you to join this social movement to stop dementia stigma. And a huge thank you. We have a long thank you slide from all of the people who supported and participated in many different ways in bringing this toolkit to life. And so I want to thank and acknowledge all of the people who shared their stories and helped with writing and putting together materials for the toolkit. And thank you all for your attention. Discussion now. We can discuss things in the chat, but we'll go through all the presentations, which are quite interlinked. And then we hopefully will have a bit of time at the end for questions or discussion. So I'm going to hand over to Deborah next. Sorry.
Thank you, Sara. It's always nice to see the final product of the work we did in Stride. I will be presenting now the intervention that we developed in Brazil. Oh, not sure what's going on here, but which is part of what Sara spoke before. So I am Deborah Oliveira. I am a nurse by background. I worked as a researcher for Stride for at least 3 years, and together with other colleagues from multiple countries, I was focused on the development of an anti-stigma intervention related to dementia. In the end, we decided to apply with community healthcare workers in Brazil. I'm currently living in Chile. That's why Adelina said I changed settings. But this work was conducted in Brazil. So just a little bit of a background. In Brazil, we have around 200 million people. It's one of the largest countries in the world. And we have recent data showing that we have between 1.8 and 2.7 million people living with dementia. Only 20% are formally diagnosed, and we anticipate that that might be probably due to a lot of stigma that we have and people that prevents people from looking for a diagnosis or getting help. In our qualitative research, we saw that people normally think dementia as being part of the natural aging process, and that might be one of the reasons. We expect the number of people living with dementia to increase to 5.5 million people, and therefore we need to increase the number of people who receive a formal diagnosis, who have access to support, and also that the anti-stigma actions go beyond individuals and affect policymakers and those who are in charge of developing services, so that everyone living with dementia in Brazil will have access to care and to support so they can live meaningful lives. In Brazil, we have a universal health system. We don't have a national dementia plan. And so we had a very good context to develop this program of STRIDE in Brazil, which has made lots of impacts in terms of movements in the national health system. Now we have at least 2 reports on the national situation of dementia in the country, which has called a lot of attention, and that on itself helps already at least raise awareness on dementia, etc. So coming back to the universal health system, we have a family care approach in Brazil. We have family care units, and so we decided to implement an anti-stigma strategy in those units, thinking that that would be the most strategic process by which we could then escalate those actions beyond the project. So we aimed to develop, deliver, and evaluate the feasibility of a group anti-stigma intervention to improve knowledge, attitudes, and behaviors in relation to people living with dementia in community healthcare workers in Brazil. And here you have the reference to the protocol, detailed protocol of what we intended to do. And why community healthcare workers? So as I said, we have this universal healthcare system across the country. Community healthcare workers, they are members of the community. They are individuals who live in those neighborhoods, who know the people around there, who know whoever is struggling with specific issues. And so they are the connection, the bridge between the community and the public services. And they are very often involved in education and community awareness, screening for dementia. They help promote utilization of healthcare and other dementia-related resources. And also they often are involved in the delivery of services to caregivers, or even of information of where to find the information they need. Besides that, besides being this bridge between the community and the public services, there is some evidence that the investments that we make in community healthcare workers have a return on this investment. So this literature here shows that every $3.16 invested in cancer prevention programs involving community health workers is sort of returned for every dollar spent in this program. And in diabetes management program, you have a return of 1.09 for every dollar spent. So you have a massive potential there, and we wanted to use this for dementia stigma reduction in relation to dementia. We did a randomized control feasibility study of this group intervention with community health workers in a city called São José dos Campos in the state of São Paulo. As you know, Brazil is massive, geographically, culturally, in every sense. So it's a very small location, but representative of very many settings that we have. We randomized primary care units instead of randomizing individuals because of the potential contact between individuals and contamination of the intervention. We did an intervention group as such, and people with treatment as usual, so who didn't receive anything else, just completed the assessments baseline, 30 days and 90 days assessment at the same time as those who attended the intervention. And the intervention was undertaken in the end of last year. Unfortunately, I wasn't involved in the implementation of the intervention because I wasn't in Brazil, but I was very close to the group who were implementing it, but I was involved in the development of the intervention. This was partly informed by a qualitative study with people living with dementia and family carers, which has been published and has been shown by Sara. It was developed by an international and multidisciplinary group of individuals, including, for example, Elaine, who is the president of our federal organization of Alzheimer's associations, and she is a doctor, a professor in linguistics. So we were very concerned about the language that we used, the strategies that we used to convey our messages. Our colleagues from the UK and our team in Brazil, we used audiovisual and printed materials, videos of people living with dementia. We used case vignettes, reflexive activities, group discussions, and presentations through PowerPoint. I have some pictures to show you then. We decided to use a wide range of materials to make it more interesting and less as if it was another activity that they had to attend. As they mentioned to us, they were really surprised by the creativity of the intervention. They didn't feel like it was an imposed sort of knowledge, and it was very much interested in what they had as a priori perception of what dementia was, and they were invited to change those views with us throughout the process of the intervention. The intervention was planned on 3 days. The first one was to build the knowledge and demystify dementia to begin this process of transformation. It wasn't telling them what dementia is and what dementia is not, but was asking them what they thought dementia was, what they thought dementia wasn't. And then they were faced with their answers and with what we had to bring to them in these discussions. And then in the second day, we had this breaking down labels and stereotypes in order to improve attitudes. The third day was very much focused on developing compassion and empathy, strengthening communication and behavioral skills, very much applied to their day-to-day practices. We did the intervention based on this theory of change that we developed. We got all the literature that we could, the qualitative research that we did, and also our international panel, our international group of researchers came together multiple times to discuss what we would include in this intervention, what would be the modality of the intervention, the target population, etc. So it was every single aspect of it was thoroughly discussed, thoroughly agreed upon, and then implemented. We were then, I put some words here, what that was like inspired us in developing the activities that we decided to implement, which was establishing closeness, not having this also within the intervention, this power dynamic between researchers and community health workers who are not in their day-to-day practice considered to be healthcare professionals. They already live on a day-to-day basis on power dynamics between them and the healthcare team that know better, if you like. So we focus on establishing empathy, reflexivity, flexibility, and developing their ability to see the person behind the disease. We try to do the intervention in their own words for their own practice. For example, we used this activity in which we had a basket, and we in the group, we did a circle of individuals, and we passed this basket with a picture of a general person, and each person looking at the basket did not know that the other was looking at the same person. And each person had to describe if that person, how was that person, for example, describe what that person saw in this individual who was in the picture, and how that person's life would change if this person developed dementia. So it had to be built on their social imaginary of what would look like if this person would develop dementia. And then another person, another picture, and the group didn't know what that person was seeing in the basket. And then in the third time, it was a mirror. And this person had to describe, she couldn't say that it was a mirror. She saw herself, or he saw himself, and had to describe how that person's life would change if that person had dementia. So they had to put up themselves in the shoes of someone who developed dementia and describe to others who did not know that it was a mirror, who that person would become or how that person's life would change. And that was a very powerful activity that we did, which definitely made them think it could have been me. It could be me one day developing dementia. We also did activities with Post-its in which they had to write down their views, and then in the third day, after discussing so much, come back to those views and think again. Do I still think this way? Has anything that I had put here changed in any way? So it was very reflexive throughout the activities. We also presented videos that is public domain. This video, for example, is a person living with dementia, waking up in the morning and doing her things around her house and going out, getting lost in the supermarket, and it's through her eyes. And people ignore her, people don't help her. And then she goes to the bank, people are annoyed because she's taking a long time to take out her cash and she doesn't remember her password, etc. And then in the middle of the video, they do the video again, but in a different way in which people help her. She doesn't feel pressured by anyone in the queue. People notice that she needs help, come to help her. So it shows different realities of how it could be in a dementia-friendly society. So it was very powerful as well. They could see the differences and feel almost as if it was them waking up and having those anxieties. You can hear in the video the person having like a fast breathing of anxious feelings by experiencing this distress. We also used narratives of day-to-day practices that they had, for example, that they heard in home care visits from family members. She doesn't want to take a bath and become aggressive. Will I leave her smelly then? No. I take her to the toilet and put her under the shower. She screams a bit and tries to hit me, but at least she's clean. So these are the kind of things that you see on a day-to-day basis, and they hear that from families. And we discussed in the sessions how to make that more human, how to make that more respectful, how to bring the person to the table and include that person's possible needs. Why is that person being aggressive? Why she doesn't want to take, or he doesn't want to take a shower in that moment? And how can the family have a better approach in those situations? So we use a lot of case vignettes to bring those things to the real life of the community health worker. So this is an overview of the activities that we used. I am not allowed to talk about the results because it will be presented. It's being accepted to present in a conference by Carol, who is the person who is a PhD student who delivered the intervention, and it would be very unfair if I spoke on her behalf. But we did have 70 people in the intervention group, 62 in the control group. The groups were no different at the baseline, and we did find significant positive differences in knowledge and attitudes, both in 30 days and 90 days compared to baseline. So there have been a longitudinal impact, if you like, on the intervention in the attitudes of community health workers. And here are just finally some very powerful quotes from them that changed the way they think and behave. I liked knowing that the patient also needs to be heard, because I have made home visits where I talked only with the family. I liked everything of the intervention, but the testimonials of people with the disease caught my attention. It changed me realizing that there is quality of life after the diagnosis. Indeed, we had one of the community health workers said in the beginning of the intervention that they would rather die than have dementia or than live with dementia. And in the end, they changed and they said, I think I would be able to live well. And I would like to highlight that I no longer would like to die if I had dementia. I would try to live as well as I could. We would treat the person with the disease in a more dignified way. I'm going to change some attitudes that I thought you were right before. I learned that even the person with dementia has preferences and would like to be heard. I now have more empathy towards my patients' experiences in any mental health issue. And I did not know the person living with dementia also suffered. I thought it was only the family who suffered. Thank you very much.
Thanks very much, Deborah. No, I know it's a really lot of careful work in setting up and developing the intervention to make sure it's relevant and appropriate for the population. And so thanks for also sharing a few preliminary results. But yeah, we'll wait
Spoiler.
for the full ones. Yes, exactly. Okay, well now we'll pass on to Christine to hear about your experience in Kenya.
Thank you, Sarah, and thank you, Deborah, for our presentation. Now I'll take you to Kenya in Africa, and I'll just be sharing. I won't be talking much about the development. I just have a few minutes, some 10 minutes to share with you on the acceptability and feasibility of community dementia anti-stigma intervention in Kenya, and I'll be using DASI. So DASI is basically the acronym of the intervention. So just to give you a background around stigma perceptions, of course, before we implemented this intervention in the local communities, there was lack of knowledge, limited knowledge, as well as negative stereotypes and discrimination towards people living with dementia and their families in the community settings. But dementia was also attributed to witchcraft, and there were weak systems in terms of detection of dementia, which would lead to, very weak diagnostic pathways, and healthcare workers were not very equipped to identify dementia. And also many family members of people living with dementia were neglected in their homes, and this resulted into abuse in different contexts. It's important to also know that stigma affects the quality of life of people with dementia and their families, but there are very minimal interventions in developing countries. In fact, one of the reports that have been reported that 70% of the reports were from developed countries, with the rest being implemented in developing countries, but none was implemented on dementia in Kenya. So we tried to do a brief survey among 59 members of the general public so that we can, and this is what helped us to actually develop the intervention among other qualitative interviews with healthcare workers, with community members, people and carers of people living with dementia. So from the survey, we found that 82% of the members of the general public mentioned that dementia is caused in part due to normal aging, and that 65% mentioned that people living with dementia should be worried about discrimination by doctors not being able to provide treatment in healthcare settings, which resulted into healthcare-related stigma. And then 62% mentioned that dementia can be, nothing can be done to prevent dementia, or they actually didn't know if dementia was preventable. And so even taking a person to the hospital was not going to be very helpful, according to the participants. And then majority of the participants, in fact, now not every 10 participants mentioned that people with dementia do not understand simple instructions. And this resulted because was as a result of dementia being detected at very advanced stages in Kenya. So some of these findings then help us to develop a dementia anti-stigma intervention, or the DASI,
So the DASI is a 4 psychoeducation session delivered by lay providers. In our context, they were delivered by community health workers. And then the first session is trying to help the community members to understand dementia by explaining to them about the signs and symptoms of dementia and activity that a person living with dementia can perform, considering that they mentioned that persons living with dementia do not understand simple instructions. And then the was addressing common myths and misconceptions, trying to use appropriate words for the word dementia in the local context, and then that dementia is not necessarily due to witchcraft. There are other factors that result into dementia. And then using videos of people living with dementia as well as their carers to illustrate some of the human rights that have been violated and how to actually overcome some of these human rights and making people understand that it is their right to be able to access care. And finally, using a case vignette similar to Brazil to illustrate the impact of stigma at the family level, at the healthcare level, and different levels, and how individuals and families can prevent stigma, as well as members of the general public can prevent stigma towards people living with dementia and their families. So this is a brief or summary of how the intervention looks like. So we trained 10 community health volunteers or community health workers in Makueni County, which is a rural county. And this is a 5-day training that involved, training the different sessions. But the 5th day was training the community health workers on using appropriate facilitator skills. And this is definitely incorporated into the manual. So it is a 4-session psychoeducational group session delivered by it was delivered by 5 pairs of community health workers, where one of the community health workers led the sessions while the other one was supporting logistics, engaging the group in trying to participate in various aspects. And as a pilot, we engaged community health volunteers deliver the intervention to 59 members of the general public, and the idea was to create awareness among the members. So that's a link to the intervention. It's publicly available. And then we measured stigma-related outcome at baseline and 1 month post-intervention. And I'm not going to talk a lot about on this slide. I'm just going to highlight 2 last bars because I realize time is not on our side and I need to give Wendy to do some final edits before we ask some questions. But it's also important to know that on extreme left, we have 26% of participants who mentioned that people living with dementia can enjoy life. But 1 month after the intervention, this number almost, doubled, and we found that 68% mentioned that people living with dementia can enjoy life. The second last pair bar, we have 85% before the intervention mentioning this is really loss of stigma at the healthcare level, mentioning that, and human rights violation, that it is okay for a doctor to force people into treatment even if they did not want to, but this number tremendously decreased significantly at 38% to mention that it is okay to force a doctor, for doctor to force people into treatment even if they didn't want to. So you can tell the difference, the improvement in some of these negative aspects, and the change in the either reduction or improvement depending on whether it was a negative or positive attribute. And then increasing dementia care spending is a useful investment. Of course, this number improved almost double after the intervention, 1 month and the intervention, various aspects that change before and after the intervention. So just to illustrate, to highlight some of the, excerpts from participants where, a male caregiver person living with dementia mentioned that in most cases, the training programs are delivered in English, but the program was delivered in such a way that they were able to understand. Some participants also mentioned that the program was quite inclusive because young people were trained, older people were trained, and they were able to actually be involved in the program. We also had improvement in knowledge, people indicating that their knowledge had improved, because one female member of the general public mentioned that they attended a session because the sessions because they have a family member with dementia whom they disagree most of the time. But after the training, they learned how to relate with this person and how to be able to respond to their questions whenever this person asks questions, just trying to even improve on the relational aspects. So what are the key lessons learned? That involving people living with dementia, their carers, and key stakeholders in developing interventions, as well as trying to implement some of these locally contextually relevant intervention, is very important to ensure that the interventions are specific to target users. And then addressing dementia-related stigma through psychoeducation sessions, as well as support by linking them to services. Linking people living with dementia to services can improve the health-seeking behavior and contribute to integrating dementia screening. And we have seen this through our program called DEMSTY, where we've been able to screen over 3,500 older adults with for dementia in rural Kenya as a result of the STRIDE DASI intervention. And then, of course, we use existing providers, lay workers, community health workers, and using task sharing approaches to create awareness, ensure that there's sustainability opportunities, and that's why this is still continuing, and the same community health workers were able to be involved in the subsequent program screening. One of the members of the general public, in fact, said that I liked our trainers. They are people well known to us to show that they actually liked. So in conclusion, let's reduce stigma and improve dementia awareness. It actually works, and you can tell this was a season. It was a marching in at the end of the intervention. You can tell people were so happy during COVID, and so why were very, very excited to just close the session. They are carrying bags of mangoes, gifts that we received as facilitators of this program. So that's the end of my presentation. Thumbs up. I would like to acknowledge the rest of the principal investigators and the rest of the research team, as well as support from other countries and LSE. Thank you very much. So at this point, I would like to invite Wendy, who is the next presenter, to take us through the.
Thanks to everybody so far. It's been so interesting, as part of the STRIDE project to hear more in more depth about what some of the interventions that have been ongoing since STRIDE finished a couple years ago. And so my name's Wendy. I'm head of research and publications at Alzheimer's Disease International. And I'm going to talk a little bit about, as Sara mentioned at the very beginning, how we're continuing on with this challenging stigma work all the way through from some of the interventions that colleagues have talked about, Deborah and Christine, from STRIDE, but then what we're doing in the future. And just to give you just a little background about ADI, Alzheimer's Disease International, we've been around for 40 years. This is our 40th year. We're the global federation of all Alzheimer associations around the world, and we represent our members internationally at WHO and the UN, and at a more regional level as well. But mainly people know us because we are really the promoters of World Alzheimer's Month, which is really about raising awareness around dementia and challenging stigma, but also the World Alzheimer Report, and that's what I'm going to talk a little bit about today. So we are doing a follow-on to the 2019 World Alzheimer Report, which is something that ADI commissioned our colleagues, Sara and colleagues over at London School of Economics and Adelina, to help us sort of get a baseline to figure out what the status was of stigma around the world. And 5 years on, we want to do it again. And, Adelina mentioned this earlier on. We've been through some of the sort of beginnings of the Global Observatory on Long-Term Care started during the pandemic. We've all been through this big thing in the 5 years between 2019 and now. And people living with dementia were discriminated against during the pandemic more than any other group, I think. What impact did that have? And also there's all sorts of sort of geopolitical conflicts going on, and people living with dementia are stuck in the middle of those as well. What happens to them? Lots happening in the world right now. We want to see what's changed. So just to just to do a little recap on what we found out in 2019, we did a global survey. We had almost 68,000 people respond to that survey, remarkably. It ran for only 2 months, and 155 countries responded, and we had over 33, well, we had 33 languages. And we found out some really kind of shocking things, eye-opening things that I think, each speaker has also narrowed some of these things down and gone into more detail in the specific countries they're talking about. But on a global level, we found out that, 1 in 4 people think that they can't do anything about dementia. So what does that mean about risk reduction and how we promote, brain health on a sort of life course? Also that over half of the carers that we talked to said that their own health, mental health and physical health suffered as a result of their caring responsibilities. 35% of carers globally said that they'd hidden the diagnosis of their loved one. But positively, over 50% of carers said that they actually felt very positive about their role caring for their loved ones. But I think the thing that really stuck out for us, and I know, Deborah, you mentioned it as well about specific statistics from Brazil, was that people really thought that dementia is a normal part of aging. 2 out of 3 people in the general public think that it's a normal part of aging. But more shockingly, that 62% of healthcare professionals thought it was a normal part of aging. And that was the one that really stuck with us, because we realized that if 62% of healthcare professionals think it's a normal part of aging, they're not going to bother to give a diagnosis. They're not going to bother to put somebody on a pathway towards support. And that also means it's going to impact on carers. And no wonder over 50% of carers are suffering, health and mental health issues around their caring responsibilities. So this was an eye-opening experience for us at ADI. And we really used a lot of this in our advocacy efforts over the last 5 years. And so why is it so important that we are doing it 5 years later? Why is it so important to actually quantify stigma? And I've been so interested in what every speaker has talked about today, about every little piece of intervention that they have tested out. Because actually, for me, I've been with ADI for 6 years now, and I see in all of my conversations with researchers, with people from policy, with our members overseas, with people that are working in industry, stigma is everywhere. It's a golden thread through every single thing that we do. And I'm sure that people that are sitting in the webinar feel the same thing, and that's why you're here. It creates barriers to someone's access to their diagnosis, to whether they're included in access to rehabilitation, whether they get access to care. It impacts what kind of treatments are available, money that goes into treatments, whether people feel fear or isolation, all of these things it impacts. And if we don't know, if we can't quantify that, if we don't, we can't make a change unless we know where we are. And so it's important to sort of understand how some of those attitudes have changed, so we can gauge our progress when we talk about raising awareness. It's really talking about including people with dementia. And Christine, you talked about this in your presentation about how important it is to include, and Deborah, you did as well, people living with dementia in the work that you're doing in your interventions, their voices. So we really do need that real world evidence. The data that we get from attitudes from dementia survey like this gives us that real world evidence that we can then use to go to governments, whether it's at a national level or at a global level, to sort of say, this is the situation in your country. This is what people really think about dementia. This is what healthcare professionals and long-term care professionals understand about it. These are some of the things that we need to change. And for us at ADI, that's particularly crucial right now, because the Global Action Plan on Dementia, which was ratified in 2017, actually expires in 2025. And so we are calling for an extension of that Global Action Plan, because as an organization that's a non-state actor, ADI being part of this global action plan on dementia actually enables us as a non-state actor to go directly to governments and challenge them in a sort of critical friend way. Why don't you have a national plan in your country, and what can we do to support you to get one? So this evidence that we're gathering is absolutely crucial, particularly right now. So here's a pause. I'm going to let you look at that QR code, and I'm going to let you get out all your phones and take a picture of that QR code, because this is the 2024 survey. We have been working alongside Sara and Adelina and colleagues at LSE to develop the questionnaire around this. If you haven't responded to the survey yet, I encourage you most emphatically to do so. It's open until the 31st of May. It's an updated version of the 2019 survey, and it is online, although there are options to do it offline if you prefer that. And we have over 30 languages, many more. Actually, we've added several languages from the 2019 report. So in a very similar way to 2019, the survey focuses on 4 different groups. It looks at people who are living with dementia, carers, health and long-term professionals, and the general public, so that we can really focus in on the experience of each of these groups of people, cohorts. As I said earlier, the survey will be open until the 31st of May. And in the actual World Alzheimer report itself, the survey will be sort of the heart of the report and give us that real world evidence. But then we're going to supplement it with the latest research, with case studies from different regions of the world and different countries, and also best practice examples, really tangible things like Sara was describing, the toolkit that can actually give people practical things that they can try in their countries. So as researchers taking part in this webinar, if you have a specific piece of research or a project that you're working on that you think we should highlight in the World Alzheimer report, please contact us. Let us know, because we'd be really interested in shining a light on the work that you're doing. This is a little, I guess we call it a heat map to show you the latest on responses of who's responded to the survey. So this is as of Monday, and the areas that are in gray, we don't really have a lot of responses from. So if you're in one of those countries, please help by starting to really promote the survey. Areas in light pink are getting up towards 400 responses in their country. And it's very important to have 400 responses in your country, because if you do, then those 4 areas, we can actually give you those 4 areas that I mentioned in the survey, the people living with dementia, the carers, healthcare professionals, and general public. We can actually give you sort of national data that you can use in your country then for advocacy efforts, which is so important, because when you start to change policy, then you can create some sustainability. The darker pink are, we're hovering between 400 and 1,000. And then I just want to give a shout out to this little country right here. Panama is the only one that's gone over 1,000. If that little country can get more than 1,000 people to respond, then surely the big countries can. So let's get working. Even here in the UK, we don't have very many. So let's keep going. And then finally, this is my last slide, just to say that we have our ADI conference in Krakow in a couple of weeks, and we're hoping to see many of you there. If not, you can still sign up and you can still join virtually. Again, I've got another QR code. So please join us and learn what's happening now, because we've got a lot of exciting people speaking at the conference. And the last slide here gives you a little bit of information of us at ADI that are working on the World Alzheimer report, and also the team over at LSE, just in case you want to get a hold of us and give us access to more information about your research. And that's it for me. Thank you.
But yeah, first, just thanks to all the speakers. It's great. Yeah, lots of different interesting examples, both in different stages of evidence that's coming out, and right, I think really important, showing that there are changes being made that we've identified from these pilot intervention programs in Brazil and in Kenya. And then thanks to Wendy for showing what we can still do even right now. Right, in terms of contributing to this survey to have really global voice represented there. But yeah, I think we have time now to open it up to questions. You can either raise your hand here or put any questions in the chat. Okay, yeah, I think I see Ashley Baston. Thanks. Yeah, please go ahead.
Right, I've unmuted myself. Hello, that was really interesting. Thank you very, very much for all the work you've put in. My name is Ashley Baston. I'm the founder and the chair of the trustees of the Lewy Body Society and the convener of Lewy Body International. I have a question from the UK, where stigmatization of dementia has been a big thing in the last couple of weeks because of the ad campaign by Alzheimer's Society UK. I wonder if anybody had any comments on what it, the view has been that it's taken all the good work we've been doing for 20 years back and re-stigmatizing dementia. I was just wondering whether you or Wendy or anybody else here in the UK had any comments.
For people who are not in the UK and haven't seen this ad, it is an ad where so the filming happens at the funeral, and it's about the experience of the son of a woman with dementia, and they keep describing her as having died at many different stages in the disease, and there has been a lot of concern that this is dehumanizing people with dementia by presenting them as dead. I don't know if that's a fair representation or description. Actually, feel free to join, but there's been quite a lot of concern that this maybe or is stigmatizing, and yeah.
But sorry, just which funeral? What is it? A movie? What is it?
So this is an ad of the Alzheimer's Society, and they film during a funeral, and they say this is her funeral, but she had died so many times before, and it's all about
Society.
how. Yes, by the Alzheimer's Society in England.
Oh wow.
Yeah, and I'm sorry. Go ahead, Ashley.
I just put it into the chat box. It's the YouTube. It's a 2-minute ad, but it ran on television and on the radio and on social media. It came out about 2 weeks ago, and Twitter was just going mad. And I've got to say, I mean, I am not stating any sort of position because it's not the Lewy Body Society's problem.
Mm-hmm.
But, it is, in watching the furore that went on, there were maybe a handful of defenses of it. We've got to show the awareness and everything, but most people were fairly horrified.
Yeah, and I think, I think it brings up such an important discussion point, because I think stigma sometimes, it comes from sometimes very well-meaning places, and I think that's what makes it, sometimes complicated to discuss. But there are some very stigmatizing views, I think, maybe coming from people trying to be well-being, but it can still have such harmful consequences. But I think, we called the toolkit "Don't Forget I'm Human," and I think that was what resonated in a lot of the focus groups and the qualitative work that we did in Stride. And for me, for example, I actually do a lot of work more in mental health, and so it was a new step for me in Stride, really, to think about what is the experience of stigma and dementia. Is it different from people with other types of conditions? How is it different? How do people talk about it? And so I was really trying to think about how to characterize it. And what came through, I think, from a lot of the qualitative work was this theme of dehumanization, which I think is definitely one of the most harmful themes. Well, I think in any kind of, in terms of any experience, but one that was really more prominent, I think, in the dementia field, and in some of the qualitative interviews, I would say, and I don't know if you want to talk about this, Deborah, just because it came up, I think, more in some of the Brazil interviews, but maybe others have something to say. We talked about it a lot because sometimes there were carers who talked about these ideas of both infantilization, like, oh, well, they're, but kind of dismissing people with dementia, or saying, right, more dehumanizing things. It's one of the themes actually in the toolkit, different quotes that come out, where people feel like, they're a shell now, and things, kind of quotes like that, and from carers who I think were coming from a place, where they really do care about the person, and that's, I think, I think that's why it is really important to discuss these ideas and hear the voices from the different stakeholders. But yeah, I mean, when I saw the ad, it resonated a lot with me in terms of, some of the other quotes we heard in the qualitative work, and actually the theme that I thought was most prominent in terms of the experience of discrimination for people with dementia. And I see, right, maybe Deborah wants to add something, and then Wendy.
Yes, that's very right, Sarah. We found in Brazil, and that was surprising for me because Sarah had experience with stigma and mental health in general, but I come from nursing and research on people living with dementia, but not in stigma. So in Stride was my first experience in researching stigma and getting into this field, and I'm passionate about it. And for me, it was a big surprise to see that most of the stigma that was enacted by family carers was very much with good intentions, and very much with trying to provide the best care possible to protect the person. But by doing that, there was a massive exercise of control and power imbalance, which was potentially would legitimize lots of practices that are restricting the opportunities and the freedom of the person living with dementia. And I think I haven't seen the ad. I'm just knowing about this right now. I haven't watched it, but I think people try desperately to convey how difficult it is, the condition. And I think the anticipated grief, as it is, was brought here in a very unhappy way. They were not very, very successful, I think, because there is lots of unintended consequences of trying to convey that view. You can speak as a family member how difficult it is to experience that, and you suffer by knowing that your family member will probably die of that condition, but in that way, transforming that in dying many times throughout life, that is a completely different story. And it really surprises me because, I mean, the Alzheimer's Society is so strong in the UK, because I lived in the UK for many years, had lots of contact with them, and they're very strong in public involvement and all of that. And how that ad came about, I mean, it might be, to me, it sounds like they're just desperate to get some money. I don't know, touching people's hearts at any cost. And this is the cost, which is probably increasing stigma in another level. But that, yeah, it's very unfortunate.
Just thinking, Deborah, and then did you want to also add something too, Wendy?
Yeah, just I mean, I completely agree. It's something that we've got a new group that we started at ADI. It's a dementia experience group. So it's people living with dementia and their carers from all different regions. And it's something that we thought we really wanted to address, like, how do you get it right? And I know my colleague Chloe, who's on the call now, who's the publishing manager at ADI, something that we've talked about for the World Alzheimer report, having some sort of case study about this. Like, how do you get it right? You know, sometimes they get it wrong. And how do you really include those voices in a way that's impactful for people that are living with a diagnosis and people that are impacted by the diagnosis, being the family carers, et cetera? You know, how do you sort of shift that narrative? How do you learn from those things? So I don't know, just a call out if anybody's doing any of that work, or we'd be interested in hearing, because it's something that has been, you're right, Ashley, on the forefront. Everybody's been talking about it here in this country. So you'll watch it, Deborah, and see what you think. Mm-hmm.
On the chat, we've got Natasha Fodor, sorry, I don't know how to pronounce your surname, Fodor Misva. Do you want to come in and mention your work on Parkinson's and epilepsy?
Hi, yeah, thank you. Just to say, we've literally just been awarded it, so we'll be starting very soon for the next couple of years from the British Academy. So myself and Mary, who was on the call, but she's actually dropped off now, we'll be looking at stigma and co-producing creative outputs to kind of tackle stigma on the coast of Kenya. So I think loads of things that we can learn from you and your successes in dementia. So I'd be really, really grateful if we could reach out to you all at some point in the next couple of years to pick your brains as well. But thank you very much for this really interesting talk.
Thank you. And Ezra Hassan?
Yeah, thank you so much for the interesting presentations. But yeah, it was just sort of my comment on the ad was, when I first saw it, was obviously a lot of my work as a PhD student is looking at how attitudes form towards dementia, but in young people, so 11 to 18-year-olds. And the data I've collected has looked at all these factors, including media, how that shapes the perception of a young person towards dementia. And my findings found that young people mainly take away negative, sort of the negative aspects from media of how that impacts their formation of attitudes. So when I saw the ad, I just kind of thought, adolescents are really overlooked, and I don't think someone often would consider how might an 11-year-old see this ad and interpret being said someone dying over and over again. So I don't know, it's just sort of made me think that, well, like, yeah, it's a demographic that forms attitudes and clearly are impacted by the media. Over 70% of the adolescent sample, and I had 1,300 something participants, and over a majority of them get their information about dementia from TV and adverts. So yeah,
there are more, but maybe if there's some people want to come back on this.
I mean, one just quick thing to say, maybe in relation to Ezra's comment, because it makes me think also of an aspect of stigma that we didn't discuss as much, but I think is related in terms of thinking of internalized stigma. And so I guess we're usually thinking of how people are internalizing that outer media and kind of societal perceptions, and that's really what drives right. There's these public attitudes that people are then influenced, and I think not only the people who live with the condition who internalize them, but you see how I think young people may be especially vulnerable to that too, right? How they're forming attitudes based on what is around them. So I think and just to say, I think that's one area maybe that hasn't been looked at as much in relation to dementia, in terms of what are those, where I think the Alzheimer's report, the ADI report on stigma attitudes, now we have this picture of attitudes out there around the world among different groups. And now, yeah, there's kind of more work to do to think about that process of then how do people react to these attitudes, agree with them or disconfirm them, and then potentially how people are internalizing them also. And I think adolescents are a really good exemplar way to think about that too.
And I noticed two comments that are kind of related with each other. So that's Charlotte and then Katy. I don't know if I pronounced correctly, or Katie. So,
Kati. Thank you.
Catherine, do you want to unmute or shall I? Or do you need to read?
Oh, sorry. Sorry, I'm actually Adelina's colleague on another project. No, I just think it's really fascinating, and yeah, I mean, I haven't come to an answer on this, but I'm endlessly fascinated by sort of what we seem to value and how that makes us react in terms of stigma. And yeah, I think the Parkinson's study sounds really interesting because absolutely the sort of, I mean, it's interesting that some people with younger onset dementia find it stigmatizing when somebody says to them, you don't look like you have dementia. And of course, what they mean is you're not old, you're not obviously suffering in some kind of way that makes sense to their internalized vision of dementia. Whereas, of course, with something like Parkinson's, if you've got the movement symptoms, it's very, very hard to hide, if indeed you wanted to, that you have that kind of condition. So I guess I was, just trying to open up that idea of, is there something a little bit worrying about the way society has moved in terms of, we're so qualifications based and we seem to really love intelligence and all things related to it, but has that made us possibly a bit more stigmatizing towards the conditions that actually destabilize that?
And Katie, do you want to come back, or Kati?
I wanted to say that there are other, I don't know that it's entirely about the cognitive part, just because there are a lot of physical conditions that are stigmatizing too. I was thinking of incontinence actually as a stigmatizing condition that's also very hard for carers to deal with. But I do think the cognition part of it, the lack of recognition, as Catherine said, also, it's just so destabilizing to carers because it feels as if it shifts the ground of why are they doing what they're doing if the person doesn't recognize them. But they place too much emphasis on the name because, as Catherine said, they can say, I know that this person belongs to me, or I know this person is familiar to me, even if I don't, I can't say their name in a sense. So that how is recognition managed in those relationships matters a lot to the carer. They want to be recognized, and it makes sense that they do because of, they're doing what they're doing because of the relationship with a person. And so how do they, reshift the terms of what reciprocity looks like? And I think that parents of disabled children find a way to feel some forms of reciprocity, and there may be things in that literature that are also would be helpful for carers helping people with dementia. So I've really appreciated these presentations. Thank you.
Do you want to? Yeah, go ahead, Deborah.
No, yeah, I was going to say that you mentioned carers, Kati. In our qualitative study in Brazil, we found that the lack of recognition of other people of the diagnosis, or this doubt, the public doubt if the person has dementia or not, generated stigma indirectly, because then the family care felt the need to emphasize the losses and the disability associated with dementia and how much impaired that person is, in order to validate their experiences. And so in order to have some social recognition or validation, the person living with dementia received many labels. Lots of stereotypes were generated around that for that to happen. And I think the lack of public knowledge on dementia, and also these stereotypical views of the suffering, as Catherine said, makes that difficult, and is clashing with our strong attempts to help people living with dementia to live well. It's almost as if by making them live well, we are not helping, because we are not credibilizing the experience. So it's a constant battle, I think.
I wasn't sure if you wanted to add anything, Christine, just from experience of Kenya in terms of the carer's perspective from your interviews or from the pilot work. Sorry to.
Yes, I know it's quite, thanks, Sarah. I know it's quite similar to other countries, but involving carers being the, because in Kenya, actually, most of the people that we interviewed were carers, because at the time, people living with dementia were detected at very advanced stages. So we got lots of information from the carers if it was aspects affecting the person living with dementia. The primary focus was on the carer until we introduced a study on Dementia where we screened more people that were able to now come forward for a diagnosis and treatment. So just involving carers and then carers being some of the primary respondents to information about the person living with dementia is very, very important, and involving them in the process. Yeah, and I'm looking forward to hearing more about Natasha's work in Kenya on Parkinson's and epilepsy.
Oh, that's great. Yeah, great to be able to make that bridge. But yeah, I think we're in our last minutes, so maybe I don't know if I can hand it back over to Adelina to close and thank everybody.
Yeah, thank you very much. From my point of view, was a fascinating, although I knew the work, it was also amazing to see how some of the intervention in Brazil has progressed. And I think it's really important to reflect that although we did achieve a lot of answers in the World Alzheimer's Report 2019 on dementia stigma, and we feel we understood what the situation was then, things look like they're changing. And this recent advert in the UK maybe is a sign. And I think it is really important that we have a good amount of answers to this survey. So please, I encourage you to share the link and to spread the word and help us reach as many people as possible, because I don't think this is a battle we've won. I think there's still a lot to do. And I also felt it was really important to see all these different aspects of stigma. And I was very happy to hear about incontinence and to also hear about Parkinson's and other areas, which just goes to show how much learning we can have across different populations and different aspects of care, and how stigma is cutting across. And I think in dementia, everything seems to come together, because we have incontinence, we have cognition, we have some, and for some people it'll be Parkinson's dementia. So we do have so much to learn across. So thank you very much. I thought that was an excellent webinar, even if I may be biased, as I know you all. And I hope to see you in future webinars of the Observatory. And please get in touch if you'd like to present and talk to us about any ideas. Thank you.